Hello doctors, welcome back to the game changer part of Dr. Sasi's session. And in this, we have two more subjects left, which is the dermatology and the anesthesia part. And we'll do this and we'll complete with this our game changer session. We'll start with dermatology and we'll move on with anesthesia, which will be our final part. We'll move ahead with dermatology. The same about dermatology. There will be around 7 to 8 questions from the dermatology part. And if you read this, it is more than enough for dermatology. Okay, don't bang your head with new things. Try to revise this notes and try to do the PVQ part. It will be helpful for you. Fine. Next, about this alopecia areata. There are different types of alopecia. One of them is what? One of them is alopecia areata. We see about this alopecia areata. It is what? It is an autoimmune disorder. It is the autoimmune disorder which affects your hair follicles. It affects your hair follicles, and because of this autoimmune disorder, what will happen is that there will be a hair follicle, and once there is this hair follicle, it will be attacked by this swarm of lymphocytes. It will be attacked by this swarm of lymphocytes. Okay, so because of this, and histologically, if you see, there will be what? There will be this swarm of B appearance of lymphocytes here. Okay, there will be swarm of B's appearance in histologically. Fine, and under the examination, this is known as strioscopy. When you examine the hair, you will be able to see this type of sign, which is known as exclamatory sign, which is known as this exclamatory sign, which is seen in a case of alopecia areata. Alopecia areata. Fine, and just if you see in a case of any other part of hair loss or any other type of hair loss, this alopecia areata, it is different. How? This alopecia name itself areata, it will cover only minimal area. It will only cover a small part of area of this head, or there will be a patchy, it will be in a patch, so there will be a patchy hair loss will be seen in a case of alopecia areata. Along with this, there will be a presence of exclamatory mark, and usually if there is a there will be two types of hairs will be there. Normally black hair will be there, and there will be a small grayish or vellus hair will be there. All of the normal black hair will be affected, whereas this vellus hair or this small grayish hair will be unaffected. That's why it will be showing this phenomena, which is known as grey hair phenomena. It is known as grey hair phenomena. They are presenting with this broken hair, which is showing this exclamation mark. Okay, and then histopathologically, you will be able to see this swarm of P appearance. Fine, and for treatment, what you will do, as it is an autoimmune disorder, you need to start with this intralesional steroids. You need to start with this intralesional steroids or this intralesional drugs. Okay, and it is a treatment of choice, or you can even use oral corticosteroids if there is more than 6 to 8 pages. Because what we will do, we will take this intra-lesional steroids and we will start applying based on the square by inch. Okay, based on the square inch we will start applying. Whereas if it is more lesions, then you need to go for oral corticosteroids. So it is an autoimmune disorder with patchy hair loss, with exclamatory sign, along with this graying of hair phenomena, and finally you will give intra-lesional steroids. You will give intra-lesional steroids. बस इतना आपको याद रखना है, ठीक है? Yeah, most of them, anything start with A and T, like it will be non-scarring. For example, alopecia areata, androgenic alopecia, fine, all of them, fine. Then about this part, which is androgenic alopecia, it is due to this hormonal changes, especially this androgenic alopecia. It is most common in males when compared to the females. In males, what will be the typical pattern? It will be what? It will be recessing of this forehead. Okay, the forehead will be starting recessing so that the hair will still keep on going backside. So it is because of this testosterone, we know this testosterone will be converted into this dihydroxytestosterone by 5-alpha reductase, and this is responsible for this conversion of this hair. Okay, conversion of this hair. So this is what, then this is what causes this androgenic alopecia. It means usually this dihydrotestosterone, which causes what? Which causes this growth of the hair, whereas here it will be mismatched, so it won't be protection of this hair will be there. Here the male pattern hair loss, if you see, this frontotemporal recession means the frontal area and temporal area, the hairline will start going back. So it is known as frontotemporal recession. It is known as frontotemporal recession. Okay, and this will be classified as Hamilton classifications. There is known as this IFU. Okay, there is this classification. Okay, just remember it is this Hamilton classification. It is known as Hamilton classification. Right? And how will you manage it? For example, this is most common in males, but it can be associated with this females as well. So if it is female, we'll give lesser percentage of this drug, which is known as minoxidil. We'll give 2% minoxidil in a case of female with this androgenic alopecia features, whereas in the case of males, we'll give 5% minoxidil. In the case of males, we'll give 5% of this minoxidil. Fine, and we can use this anti-androgen drugs, Okay, like for example, 5-alpha reductase incubators. 5-alpha reductase incubators. Like actually, what does this? It will convert this terminal hair, this proper black hair, into this villous hair. It will convert this terminal hair into this villous hair. Because of this, there won't be any proper terminal hair, and all of this terminal hair will be lost. Only the villous hair will be left. Okay, just remember, only the villous hair will be left. Yeah, good guys. The 5-alpha reductase incubator, one of them, it is what it is this drug which is known as 5-alpha reductase incubator, which is an finasteride. It is an finasteride. Fine, remember. And then you must be seeing a psychiatric female or a female, psychiatric female, or mostly a females, is presenting with this emptiness or the area which is easily accessible, which is having this patchy hair loss. Okay, there is a patchy hair loss in accessible areas. Yeah, accessible areas, and along with this, hair with variable length. Hair with variable length. Okay, and on examination, you will be able to see this perifollicular hemorrhages. Perifollicular hemorrhages. So all of this thing, hemorrhages. So all of this thing where there is in accessible areas where you will be able to get this patchy hair loss, and then hair of different lengths. Like one is this length, next one is this length. So hair with different length, and along with this, because of pulling, there will be a bleeding happening there. So this leads to this perifollicular hemorrhage. So all of them will be classically seen in a case of trichotillomania. Yeah, good Dr. Gautam, good Dr. Parul. This is seen in the case of trichotillomania. And remember, this trichotillomania, then the patient can be a psychiatric. So in such cases, he can eat. So it is known as trichobasor. Trichobasor. Okay, trichobasor. So these are the few alopecia that you need to remember of. Okay, this androgenic alopecia and alopecia areata. Okay, there is two more types of alopecia. They are known as effluvium. One is known as androgen effluvium, another one is known as tenogen effluvium. Remember, anagen effluvium and telogen effluvium. This anagen effluvium, it will be happening in a case of chemotherapy. Whereas this telogen effluvium will happening in a case of tension cases. For example, when there is a tension, okay, during the phase where there is a pregnancy, where there is a chronic illness. In such cases, this telogen effluvium will be happening. So telogen will be happening in tension, or an anagen effluvium will be happening in a case of chemotherapy. In a case of chemotherapy, especially. Remember this thing. Yeah, good guys. Next, we'll come on to this few nail changes. If you're able to see this type of elastotic degeneration, which is known as what? Which is known as pterygium, and this pterygium will be classically seen in a case of Lichen planus. Lichen planus, you will see this pterygium. And next, if you're able to see this type of fingers, where this, instead of like this fingers, it will become like a drumstick, and the angle is not maintained. Smooth angle is not maintained. So it is what it is, this clubbing of the finger, which is especially seen mostly in a case of pulmonary disease and few cardiovascular disease also this may see. Okay, remember, it is mostly seen in a case of pulmonary disease where there is decreased oxygen fusion. Okay, diffusion. Remember, yeah, there is a features of, it is a features of hypoxia. Next, if you are able to see this type of spoon-shaped nails. Spoon-shaped nails, these are typical for this spoon-shaped nails. They are typical for this iron deficiency anemia. They are typical for this iron deficiency anemia, which is known as koilonychia. Koilonychia means spoon-shaped nails. Remember, fine? Yeah, good. And okay, fine. Next, if you are able to see this type of whitish lines. Able to see this type of whitish line which is seen here. This type of whitish lines on this nail bed. It is known as what? It is known as Ullrich-Mees line. You know this type of Ullrich-Mees lines. It is classically seen in a case of poisoning with arsenic, and it can also be seen in a case of gallium poisoning. Okay, remember, yeah. This type of whitish line, it is what it is seen in a case of arsenic poisoning. Next, if you are able to this type of nails where there is this presence of leukonychia. This type of leukonychia will be classically seen where there is presence of this decreased protein amounts. For example, they are known as Terry's lines. They are seen especially in the case of liver dysfunctions like cirrhosis, or it can be seen in a case of congestive hepatic failure or diabetes mellitus. So all of these conditions, especially in the case of any liver pathologies like cirrhosis, can present with this stereo nails. Fine. Next, if you see this next nail, which is known as half and half nails. Okay, half and half nails, it is known as Lindsay nails, and this Lindsay nails, it will be classically seen in a case of renal failure. Okay, so this is the cirrhosis and congestive heart failure. Okay, heart. And so this half and half nails, also known as Lindsay nails. Okay, see, it is half, and it is also apparent leukonychia. Means you see this is looking like half of the nail is white. So in this apparent leukonychia, it is known as what? Half and half nails, also known as Lindsay nails. Fine. And next, if you are able to see this type of things, they are known as what? They are known as pitting. This pitting, there are two types of pitting. One is known as regular pitting, and another one is known as irregular pitting. Irregular pitting. See, regular means this is the regular pitting. Whereas irregular matlab, you will see one is small, one is large, one is small, one is large. This is irregular pitting. This type of regular pitting will be seen in a case of alopecia areata. Whereas this type of irregular pitting will be seen in a case of psoriasis. Okay, psoriasis. Fine. Next, if you are able to see this nail where there is around this nail bed, you will be able to see there is a pus formation due to the infection over here. That is known as paronychia. Around the nail, it is known as paronychia. Okay, paronychia. And we know the most common cause of this skin and scalp tissue infection, it is mostly what? It is this Staph aureus infection. It is the Staph aureus infection. Fine. Next, if you are able to see this type of oil drop sign, it is also seen in a case of psoriasis. Then, if you are able to see this lysis of this nail, it is known as onycholysis, or separation of the nail, it is known as onycholysis. Next, if you are able to see this nail, it is being separated from this finger. So there is huge separation here. So this type of thing, which is known as happens due to this subungual hyperkeratosis. This is known as subungual hyperkeratosis, which can be seen in a case of fungal infections. Okay, remember, yeah. That is, oil drop cataract will be seen in a case of galactosemia. See, oil drop cataract will be seen in a case of galactosemia, whereas oil drop sign in the nail will be seen in a case of psoriasis. Remember, fine. Next, if you are able to see this lamp, this is known as wood lamp. Okay, this wood lamp, it is used to assess this skin lesions, especially the macules or lesions. Right? The most commonly, the wavelength which we use here, it is this 360 nanometer, and the component which is made up of means this there will be a filter. This filter of this wood lamp examination, wood lamp is made up of this barium silicate and 9% nickel oxide. It will be made up of barium silicate and 9% nickel oxide. So just remember, it will be made up of barium silicate and 9% nickel oxide. And based on the color which is be seen from this wood lamp examination, will tell, yeah, it might be this disease. First, the most common one which is being tested, it is what? It is known as erythrasma. In the case of erythrasma, what you will see this coral red fluorescence. So remember, in the case of erythrasma, you will see coral red fluorescence. If you can see bright apple green or yellow green, fluorescence will be seen in a case of tinea capitis. In the case of tinea infections, you will able to give, especially in the case of capitis, you will able to see this yellow green or apple green emissions, or else in the case of vitiligo, we know vitiligo is white color. So here you will able to see bright white kind of discoloration in the case of wood lamp examination. Okay, see. Next, if you are able to see this green is Pseudomonas, we know it produces multiple colors. One of them is what? It is a greenish color discharge. Okay, and it is the most common cause of corneal ulcer in contact lens ulcers. Fine. So this produces this green color fluorescence. Whereas in the case of melasma, we know melasma right here. Melasma will be there for which will give this hydroxychloroquine, mostly seen in elderly patients, and this melasma it will be dark brown in color. Fine. Whereas this Purpurea cutaneous tarda, it will be red in color. Purpurea cutaneous tarda, it will be red in color. Okay. Then we'll move on to this part where we discuss about this ulcers. Okay, about the sexual transmitted disease and the ulcers. See, you need to try to differentiate. What is the first differentiating factor? In question, there will be mentioned there is a 30-year-old male. There will be what? There will be a 30-year-old male who is truck driver by profession, and he had a recent unprotected sexual intercourse. Fine. And now he is presenting with the type of lesion. If they're presenting with painful ulcer, remember painful. If someone is in pain, he will cry. So remember, it is the chancroid, or it is caused by the Haemophilus due cry. So remember, if he is cry, it is because of this cryoid. So remember, it is the chancroid will cause this pain. Okay, it will cause this pain. Okay, what are the painless ulcer? Like, okay, if you take up this LSD, this is a drug, then you will feel everything is you are in euphoric state. So you will feel painless. So this LSD conditions will be having this painless ulcer. What are the LSD conditions? One is this lymphogranuloma venerum. Fine. Next one is this syphilis and the Donovanosis. Okay, Donovanosis. So this is the first thing. If they say painful ulcer, then you need to point your diagnosis towards Haemophilus nuclei. Then you should move on to this. If there is any vesicles present or not. If vesicle presence, then you need to think of herpes simplex infections. If not just ulcer, then you should think of Chancroid, which is caused due to the Haemophilus ducre. Fine. So then how will you differentiate? They will tell if there is a single ulcer if present with the presence of induration and there is no pain on evaluation you will able to see the patient had this infection very long back. If the incubation period is between 9 to 90 days and there is a single ulcer along with this presence of induration which is and the ulcer is painless. Okay, this is the typical feature of syphilis. This is the typical feature of syphilis. Right? Whereas if you compare this syphilis with the next, which is this chancroid. Okay, chancroid, if you see, as I told, syphilis it will be painless. Whereas chancroid it will be painful in nature. It will be what? It will be a painful in nature, and here it was a single ulcer. Whereas in the case of chancroid, it will be multiple ulcer. There will be a multiple ulcer. Fine, and here the induration will not be present. Okay, and this will be very fragile ulcer. Once you touch, it will bleed. Once you touch, it will bleed. So this chancroid will be once you touch, you will bleed. The ulcer will bleed. Like that kind of presentations will be there. And there will be a presence of lymph nodes which will be mostly unilateral in nature. And as I told you, there will be a painful ulcer. There will be a painful ulcer. Fine. And now next if you see about this Donovanosis and lymphogranuloma venerum. If you see about this Donovanosis and lymphogranuloma venerum, then you just see this Donovanosis and lymphogranuloma venerum. Both of them they will be having this single ulcer, and both of them they will be almost painless in nature. Okay, here LGV also is almost painless. Remember, fine. And this, if you see about this Donovanosis, it will be a very firm ulcer which is granulomatous in nature, and there will be association of this pseudobipo. Whereas lymphogranuloma venerum will be associated with this bilateral lymph node involvement. Bilateral lymph node involvement will be present. Just remember, if it is bilateral pubos will be present, it will be LGV. Whereas in the case of Donovanosis, you will see there will be pseudobubo formation. Currently presence of pseudobubo formation. Okay, so Donovanosis and LGV you need to differentiate. Fine. Then they both will be having this painless and single ulcer. Whereas in the case of Donovanosis, they will call it as red beefy ulcer, which is also having the features of bleeding. Okay, so there will be red beefy ulcer. Okay. This is the case of Donovanosis. Fine. This will be typical like this. There will be a red beefy ulcer. When you touch, it will bleed. Fine. And in the case of text, as I told you, HSV, it also will be having this painful ulcer. But if you see about this painful ulcer, it will be having this multiple, and it will be having this polycyclic ulcers. Means there will be 1, 2, 3, 4, 5. There will be multiple ulcers which are coming together. There will be multiple ulcers which will come together and will form a single ulcer. So it is known as polycyclic erosions. And we know it will be caused by this HSV2. Mostly whatever it's below the waist, it will be caused by this HSV2. Itna yaad rakho. So okay, fine. So these are the things. Painful means it is chancroid. Painless means LGV, syphilis, and Donovanosis. You just remember. Fine. And this is the case of secondary syphilis, where you will see. In the case of secondary syphilis, after starting of treatment, if you are able to see this type of phenomena where there is a presence of red rashes in the hands, okay, this is seen in the case of secondary syphilis after initiation of this treatment. Fine. Next, if you are able to see this type of friable ulcer, which is painful, it is what it is, this Haemophilus ducre. Okay, and then if you are able to see this type of red beefy ulcer, this is typically seen in a case of Donovanosis. Fine. And next, if you are able to see, there is two suppurative. This is suppurative lymphadenopathy. causing this formation of groove in the inguinal region. So this is known as formation of buboes. So this buboes formation will be typically seen in a case of which one? Lymphogranuloma venerum. It will be caused by the lymphogranuloma venerum, where we will see this groove sign. Fine. And management, we know, in the case of syphilis, we'll give benzathine penicillin, whereas in the case of Haemophilus decuri, which is this chancroid, we'll give azithromycin. Okay. Where same for this lymphogranuloma venerum, we'll use both azithromycin and doxy. Donovanosis also will use azithromycin. Okay, azithromycin. Fine. That's it, guys. It's how you will be able to differentiate this type of ulcers based on their characteristics. Okay, Okay, and then we'll move on to some of these papillosquamous disorders. Okay, if you see about this papillosquamous disorder, at least one of them it will be tested, either Lichen planus or there will be psoriasis. Within these two, they will test at least one. See, in the case of Lichen planus, they will tell there is this purple polygonal pleuritic plaques. And it is present on the flexural aspect. And if they are presenting on the flexural aspect, this is the typical feature for this Lichen planus. And this is also an autoimmune disorder. Okay, autoimmune disorder which is having this kind of purple pleuritic plaques. Okay, polygonal plaques will be seen in the case of Lichen planus. And if there is an involvement of this oral cavity, where there is formation of this white lacy pattern, this is known as what? This is known as Wickham's striae. And next, if you see this, as I already shown you, right? If there is presence of this nail involvement, and if there is a degeneration like this, it is known as pterygium, and it is typical for this Lichen planus. Fine. Whereas we saw this pterygium, right? It is also what? It is the elastotic degeneration of this conjunctiva. Okay, it is the elastotic degeneration of the conjunctiva. Okay, don't forget those also. Okay, and we know this pterygium, it can lead to this astigmatism. Okay, and if you do exercise of this Lichen planus, then you will able to see this type of bodies. They are known as what? They are known as civet bodies. You will able to see this civet bodies. Okay, civet bodies. Fine. And here also you will able to see, as I told you, it is an autoimmune disorder. This autoimmune disorder will cause us this lymphocytic infiltrate. Okay, don't forget. So there will be civet bodies and there will be a presence of this lymphocytes because it is an autoimmune disorder. Okay, autoimmune disorder. Fine. And as it is an autoimmune disorder, what will go? We'll give this steroids like oral and topical corticosteroids, and along with this calcineurin inhibitors like topical tacrolimus and pimecrolimus. Okay. Okay, tacrolimus. Okay, remember. Then we can use one more therapy which is known as UVB phototherapy. We can give this UVB rays with or without application of this drugs, and once the UVB's risk exposure, these lesions will tend to reduce. Okay, So this is this Lichen planus. Okay, it will be having this purple polygonal pleuritic plaques, especially on the flexural involvement. Okay, there will be presence of Wickham's striae, and there will be a presence of this pterygium, and for treatment will give corticosteroids, and HP will see this civet bodies. Yeah. Next, if we see about the psoriasis, you know the psoriasis, it is also one of the most common one. It will be having this extensor, like in planus it was flexor, whereas psoriasis it will be having this extensor involvement. So Auspitz is having this extensor involvement. There will be extensor involvement with silvery white micaceous scales. Extensor involvement with is having this silvery white micaceous scales. And once you remove one scale, and peel and see this, then you will able to see there is a bleeding spot inside. So this type of bleeding spots, once you remove the scale, it is known as what? It is known as Auspitz sign. Which is seen in a case of psoriasis. Once you remove a scale, you will see there will be a multiple bleeding spots like this. So this is known as Auspitz sign. Okay, this is known as Auspitz sign. And we know this HLA CW6, it is being associated with this psoriasis. The psoriasis will be associated with this HLA CW6. Okay, whereas we know ankylosing spondylitis, it is associated with this HLA B27. Remember. Fine. And next, on histopathological examination, you will see two things. Okay, one is known as Kogoge pustules and another is known as Munro's microsubsess. Okay, Munro's microsubsess and Kogoge pustule you will be able to see in the case of psoriasis. So remember, it is this MP. Okay, Munro's microsubsess will be seen in the case of psoriasis. Okay, Just remember. And here you will be able to see, we know, usually when the skin come from the superficial to the, means deep to the superficial layer, skin will become flattened. And when it reaches from this to this stratum corneum layer, then the nucleus will be absent. If the presence of nucleus in the stratum corneal layer, we'll call them as parakeratosis. Yeah, we'll call them as parakeratosis. Yeah, good guys. We'll call them as parakeratosis. And instead of one layer, if there is multiple layer which is causing this formation of this silvery white micaceous scales, this is known as what? This is known as hyperkeratosis. So it will be having both hyperkeratosis and parakeratosis. Remember, fine? And two abscess, Fogos pustules and Mundros micros abscess. Fine. And once you start scratch, for example, here you had this psoriatic lesion, but you scratched here. When you make a trauma, then what will happen is that whenever you make trauma, the psoriatic lesions will start developing to the regions where you make trauma. So when you do like this, it will start next day or after a few days, there will be a formation of this silvery white micaceous scale blocks will be present on this extensor surface after exposing to this trauma. Okay, fine. And as I told you, this is an extensor nerve. Okay, there are a few more types of psoriasis that you need to know. For example, if there is this type of psoriasis which occurs in this females, pregnant females, okay, it is known as impetigo herpetiformis. Okay, and the treatment for them, it is what it is, the steroids. So only in this case we'll use this steroids. Fine, steroids will use. Fine. Whereas in next case, if you see, there is this presence of around the same type of pustules. Here also pus is there, here also pus. But this is known as lake of pus or this pool of pus. There will be a huge pus. There will be a lake of pus. So it is known as this lake of pus. It will be present in a case of pustular psoriasis, which is known as von Zumbuchki reaction. Okay, and von Zumbuchki reaction, it is due to this over treating with the steroids. It causes this pustular psoriasis, which is known as von Zumbuchki reaction. Fine. And next, if you are able to see this type of raindrop kind of psoriasis, yeah, good guys, raindrop kind of psoriasis, it is known as what? It is known as guttate psoriasis. Good. Fine. Next, if you are able to see, there is this whole body along with the scales, there is a formation of this red. It is red, erythematous. So it is known as what? Erythrodermic psoriasis. Okay, erythrodermic psoriasis. Next, as I told you, this psoriasis will involve this extensor surface, but instead of extensor surface, if it start involving this flexor surface, like for example, inferior to the breast or mammalian or into this axillary region, so if it starts involving this flexural region, so it is known as what? It is known as inverse psoriasis. Next, the psoriasis, if it start affecting this hands or this bones, it is known as what? Psoriatic arthritis. It is known as psoriatic arthritis. And remember, the psoriatic arthritis, it will especially love this place, which is known as DIP. Okay, DIP, it will be love to affect. So it will lead to this type of deformity, which is known as pencil in cup deformity. Okay, pencil in cup deformity. Okay, it is known as pencil in cup deformity. Okay, yeah, good. And for treatment of this, we'll use methotrexate. Okay, on evaluation, you'll be able to see this is the sausage disease. Sausage digits with pencil in cup deformity. Yeah, we'll use this methotrexate. Good guys, good. Fine. So usually in the case of psoriasis, what we'll do? We'll give moisturization and we'll give corticosteroids topically, and we'll start with retinoids. Okay, like usually with topical retinoids like azorotone and any other calcineurin inhibitors. Okay, and we have two regimes where we use this UV lights. Okay, where we will use this UV lights and this sunlight. See, one regimen, it is known as Gakeman regime. Okay, in Gakeman regime, we'll use this coal tar. We'll use this coal tar placed and we'll apply for this apply to the skin and will expose to this phototherapy unit. Fine. Whereas in case of Ingam regime, what we'll do, we'll apply the anthraline paste. Okay, in the case of GC, remember it is CG or GC, in Geikman's regime, what we will do, will apply the colta. Whereas in the case of Ingram's regime, we'll apply this anthralin paste and will undergo this phototherapy. Okay, and phototherapy usually will be what? Will be having this UVA phototherapy with psoralen. With psoralen will having this phototherapy, and it is being used for this psoriasis, remember. And for psoriatic arthritis, I told we'll use methotrexate. Arthritis, yeah, we'll use methotrexate. And next one, it is what? It is this. This is which is known as acne. In the case of acne, it is what? The typical case of acne, which is mainly due to what? It will be due to the infection and along with this hormonal changes. Infection along with this hormonal changes, and the typical form and the typical the most consistent finding in the case of acne, it is what? It is known as this one, which is known as what? Comedones. Comedones are also known as black dot. Black dot also known as comedones, fine. And this is due to this blockage of the sebaceous glands, fine. And this can even lead to this type of complicated acne, which is known as what? Which is known as, what is the name of this complication of this acne, guys? It is known as nodulocystic. It forms nodules and cystic. Yeah. If you see this comedones, if it is black dot, it is known as open comedones. Right? It is known as what? Nodulocystic disease. Yeah. So it is mostly involved, means this acne, it is mostly involving the seborrheic areas where there is sebous hyperplasia due to this androgen or this comedones. There will be this follicles will be alterly differentiated. That's why it will become this comedones. Okay, comedones, fine. And there will be this, sometimes there can be associated with this papules and pustules formation, and that's why when you remove, when you crush it open, you will be able to see this pustules, fine. And finally, it will be scarring, mostly this eye scarring the vital, like it will scar and heal, fine. And there are different stages. In stage 1, stage 2, stage 3. What you will see? You will see comedones for sure. That is this black dot. And followed for this, you will start with the same topical retinoids. And if there is any comedones along with this inflammatory papules and pustules, then we'll give topical retinoids. Along with this, there is a pustules. So there may be chances of infection. So we'll give antibiotics. So we'll give pustules. For pustules present along with comedones, we'll give antibiotics. इतना याद रखो. फिर उसके बाद आते हैं grade 3. Grade 3 there will be multiple inflammatory papules and pustules. Inflammatory papules भी है और pustules भी है. Then we'll give topical retinoids along with topical antibiotics and antibiotics. Topical and oral antibiotics हम दोनों देंगे. But in the case of nodulocystic disease, it is a very severe form. In such cases, we'll start with isotretinoin. We'll start with isotretinoin. और हमें पता है the most common side effect of this isotretinoin है, it is the dryness of the lips. Dryness of the lips, it will be caused by this oral isotretinoin. And in later part or in pregnant female, what will happen is this can even cause teratogenicity. This can even cause teratogenicity. Okay, fine. And next about this part, which is known as contact leukoderma and contact dermatitis. Fine. Leukoderma, it is nothing but this whitening. Okay. Whereas contact dermatitis, it is when there is area, there will be starting of this dermatitis. Fine. Okay. So just remember this allergic contact dermatitis, it is a type 4 hypersensitivity reaction. Yeah. Good enough. It is a type 4 hypersensitivity reaction. And next, it will be sudden in nature. Whereas leukoderma, it will take some time. Fine. It won't be sudden, it will be take some time. Okay, because you got a new detergent, you got a new watch, it will start like you wear it and tomorrow you're getting, like it will take some time to occur. Fine. And it is subsequently exposed to the antigen, like after the first exposure, usually like previously formed Nichols, or previously you were using this detergents and again you were exposing to same. Fine. For example, the most common one in the case of jewelry, it is what it is, the nickel one. Okay, whereas it can happen because of this bindi. Okay, bindi, actually it is leukoderma. It can happen because of the bindi, which is known as what? Which is known as bindi dermatitis, which is due to this PTBP. It is due to this PTBP. Okay, paratertiary butyrophenol. Paratertiary butyrophenol will cause this bindi leukoderma, bindi dermatitis. And if you see in the case of hair dyes, it will cause inflammation over here, which is due to this paraphenylalanine. Okay, it is the PPD which causes this hair dye. This causes this hair dye induced allergic contact dermatitis. Fine, and it can even lead to this type of contact leukoderma. Remember, it can lead to this. Finally, as a complication, can lead to this contact leukoderma. Remember. Okay. Next, to know this allergic contact dermatitis, we'll use this test. What is the name of this test, guys? इसका नाम क्या है? It is known as what? It is known as patch test. Good guys. This is the patch test. And here there will be this aluminum chambers will be there, and we'll keep one allergen one by one, and we'll pick as a paste. And most commonly we read after 48 hours, but the best reading can be done at 96 hours. Okay, it is used to detect the allergens. And we know it is also what? It is also type 4 hypersensitivity reaction. Yeah. Okay, so this is the patch test which is used for this allergic contact dermatitis. Fine. Then we'll move on to this most important one. It is what it is, this Pemphigus group of disorders. You see about this Pemphigus group of disorders. This is this Pemphigus vulgaris and Bullous pemphigoid. See, Pemphigus, Bullous pemphigoid. Like if you see about this old age patients, they will be always tensed. So if you see there is a lesion which is occurring in this old age patient and causes this tense bullae. Tense bullae which is occurring in the old age patient, it is what? It is the Bullous pemphigoid. It is the Bullous pemphigoid. So it is in elderly patients, and there will be what? It will be tense. If you see, this is very tense. Okay, this is tense, and it won't involve these mucosal regions. Okay, and it will produce what? It is produces this subepidermal clefting. It is due to this subepidermal clefting, and immunofluorescence. If you do, especially direct immunofluorescence, you will able to see linear deposit. This type of linear deposits in a case of direct immunofluorescence. Linear deposit. Okay, linear deposits of this IgG. Okay. For this management, you give this systemic or topical glucocorticoid. Fine. And next condition, which is known as Pemphigus vulgaris. There are two Pemphigus group of disorders. One is known as Pemphigus foliaceus, another one is known as Pemphigus vulgaris. Remember vulgar. Okay. How you will tell the vulgar words? By your mouth. So remember the gali muh se nikalte hain. Okay, so remember. So whatever the vulgar words you will use with your mouth. So remember this, in the case of Pemphigus vulgaris, your mouth or this oral mucosa will be, affected. In the case of Pemphigus vulgaris, fine, there will be affected. Next, if you are able to see, this will be what? This won't be a tense bulla. This will be what? This will be having this flaccid bullae. And direct immunofluorescence, it will show this type of pattern, which is known as what? Fishnet pattern. And here, like for example, remember you told gali, means you told any bad words, and once you say bad words to a bigger person or a elder person, then they will kill you and they will make you a tomb. Okay, they will make you a tomb. They will bury you and they will make you a tomb. So remember, in the case of Pemphigus vulgaris, you will see this fishnet appearance, or they will put fishnets and they will catch you and they will kill you, and they will they will bury and they will put a tombstone. So remember here on a histopathological examination, you will see a row of tombstone appearance. Tombstone appearance. Okay, and once you apply pressure over this bulla, then what will happen is that this bulla will break, and this type of sign, which is known as what? It is known as Nikolsky sign, will be positive. And here the antibodies against this desmoglin 1 and 3, whereas in the case of Bullous pemphigoid, it is due to the antibody against this Bullous pemphigoid, antigen 230 and 180. Okay, here I told you it will be producing this type of fishnet appearance. Okay, about this too. Next, about HSV, I told you this is this herpes labialis, which causing this multiple vesicles, which is forming this polycyclic ulcer. Okay, polycyclic ulcers. Fine. Then HSV1, it affects above the waist, HSV2 below the waist. Fine. And yeah, HSV causes herpetic gingivostomatitis and herpes labialis. That is the formation of this what? That is the formation of painful vesicles around the border, which is known as vermilion border. Fine. And this virus can stay dormant and it can cause reactivation. Okay, reactivation. So topically, it will give antimicrobial and prevent secondary infection as well. Fine. And in genital herpes also, it can remain dorsal. Okay, and this will produce this polycyclic erosions with bilateral painful lymphadenopathy. Okay, see, there is two painful ulcers. One is what? One is this Chancroid, next one is HSV. Whereas HSV produces this polycyclic erosions, whereas Chancroid will be producing this very friable ulcer will be there in the case of Chancroid. Yeah. And on Zank's smear, and on Zank's smear, you will be able to see there is this multinucleated giant cell. Multinucleated giant cells will be seen in the case of Zank's smear. Fine. And we'll come on to few warts. If you see this type of individual warts, this is known as what? This is known as condyloma aquinata. Whereas if you are able to see this type of this type of warts where there is this cauliflower growth. Cauliflower growth. What is this one? Yeah. What is this one, guys? It is also the condyloma acuminata, which will be having this cauliflower or giant condyloma acuminata, which is showing this type of cauliflower-like growth. Okay, and most commonly it will be caused by this HPV 6 and 11. It will be caused by this HPV 6 and 11. Whereas high risk HPV, which include 16, 18, 31, 35, it will cause us this cancer. It will cause us the cancer. Okay, especially 16, 18 is responsible for this cervical cancer. It is responsible for the cervical cancer. Fine, and it can predispose to malignancy, as that's true, and it will be a large. Then it will call it as giant condyloma acuminata, like which is also known as Buschke-Lowenstein tumor. It is known as Buschke-Lowenstein tumor. Yeah. Now, first is also condyloma acuminata. It is also condyloma acuminata, whereas this is second one is giant condyloma acuminata. Condyloma lata, it won't be like this warts. Condyloma lata, it will be kind of flat papules, like flat will be there. It will be flat, whereas here it will be wart. Okay, I guess you will be able to get the difference. Like, so condyloma lata, that is kind of nodules or nodules kind of thing. It will be flat, will be there with small rise. Okay, and it will be seen in a case of syphilis. Okay, that will be seen in a case of, yeah, first was looking like flat. Now if you see, the flat means it should be like this will be there. See, here it is enlarging incoming. So it is the warts. Okay, that is how. Like there will be a small differentiation that you should have the clarity. Once you see those images, you will be able to get the clarity. Fine. Next, in the case of this HPV infections, you will be able to see the presence of coilocytes. Fine. Then treatment, they asked it, how will you treat this type of wart? Fine. If you see these general lesions, we can use podophyllin or imiquimod or TCA. All of these things we can do. But whereas if there is a pregnant patients, we can usually use cryotherapy induced ablation, or we can use this TCA application. This apply TCA, after that it will become fall off. Okay, it will fall off. Remember, fine. And this HPV, it is involving in different diseases. You can remember as different types of HPV, so different diseases. So deep plantar wart, it will be caused by this HPV1, whereas HPV2 S for S. So second, it will cause this superficial plantar wart. 3 will cause this plain wart. So remember, the plain wart, it will be caused most commonly by 3, not by 1. Fine. And common warts, it will be by these 3 common people is 4, 2 and 27. Whereas ED, fifth alphabet, that is this epidermo dysplasia verruciformis will be by this HPV5. Will be by this HPV5. Right? Next, anogenital warts, as we know this is 6 and 11. Okay, and then Butcher's wart, which is happening from this spreading from this animals, it is known as HPV7. It is by this HPV7. So remember this condyloma acuminata, it will be by this HPV 6 and 11, whereas CA cancer, CA cervix, it will be especially from the 16 and 18. From the 16 and 18. Fine. I guess you got it. Next, you say a patient who is presenting with this increased pruritus in evening. And along with this, there is a nodules in scrotum, and here, yeah, and here in between this web space, in between these fingers, he is able to see there is this excoriations. So this excoriations between fingers. Okay, all of these things will be classically seen in a case of scabies, and we know this is the age at which responsibilities. What is the Sarcopsis? It is a Sarcopsis scabi, and it will produce this typical lesions, which is known as what? Burrows. It is known as typical lesions, which is known as burrows. Fine. And if it is happening in a homeless people, then there will be this millions of mite. It will come and attach to the skin, or it will lay eggs. It will eat there. It will sleep there. Though it is known as what? It is known as Norwegian scabies. It is known as Norwegian scabies. Okay, remember. Next, for treatment of this, will give what? Will give 5% permethrin. Okay, will give 5% permethrin. Okay, if it is chota bacha, if it is a children, then we'll tell this don't apply on the face. Okay, apply at the night. Okay, on 0 and 7th day, on 0 and 7th day, open a bottle of this permethrin, means permethrin solution. Then just pour and apply all over the body during your night, and once you wake up, just bath. Okay, this is how the application of 5% permethrin. If it is child, we won't tell them to apply over the face, like around until 12 years, and after that, if it is adult, we can tell them to even apply around the face. Okay, just remember. And for this, we'll use this 5% permethrin cream and also ivermectin as a oral drug of choice if it is in case of severe. Fine. Okay, the cream has to be applied from neck to toes to overnight in a case of children for like and it is repeated after 0 and 7th day. Fine. And oral use of drug of ivermectin, like what will be like it will be used 200 mcg per kg. Like usually we'll give 6 to 12 mg. Okay, 6 to 12 mg based on the dose. Like RLs, if it is adults, will give usually 12 mg. So remember 5% permethrin and ivermectin. These are the two drugs which you use for a case of scabies. Okay, for this case of scabies. Fine. And next we'll see about the tinea. These are the fungal infections. If you see, this is the black dot forming. This is the tinea capitis. And tinea capitis have other forms as well. So if you're able to see this type of scutula formation, it is known as what? It is known as favus. It is known as favus type of tinea capitis. Whereas if you're able to see this type of tender, it is looking like a tender and boggy swelling. Okay, tender boggy swelling, and when you pluck a hair, this will come easily. So tender boggy swelling along with this easy pluckable hair, it is a typical feature of this Kirian. Remember. Fine. And next, if you are able to see this type of central clearing, okay, if there is a body, if there is a dead body inside, then what he will do? He will keep it and do puja? No. What he will do? He will dispose it. So remember, the central clearing will be seen in a case of tinea corporis. So if there is a corpus, then we'll remove it. Remember, it is the tinea corporis. It will be presenting with central clearing. Remember. Next, if you are able to see around this inguinal region, it is known as what? Tinea cruris, also known as jock itch. Fine, jock itch. Next, if it is involving this foot and along this web spaces, it is known as what? Tinea pedis, also known as athlete's okay, athlete's foot. Fine. And next, most of the drug of choice for all the tinea, it is what? It is the terminophen. Except in a case of tinea capitis, we'll use this griseofulvin. Except in a case of tinea capitis, we'll use what? We'll use griseofulvin. Fine. And next, about leprosy. If you see about this leprosy, like if it is presenting in the small child, which is looking like this patch, okay, it is looking like this hyperpigmented patch, it is what? It is this with multiple hyperpigmented patch, it is what? It is this indeterminate leprosy. Whereas if you are able to see this type of saucer which is in upright position, it is seen in a case of PT type of leprosy. Whereas if you are able to see this type of satellite lesion, this will be typical for this BT type of leprosy. In the case of BT type of leprosy, we are able to see this satellite lesion. Yeah, good guys. Yeah. Fine. And there is this indeterminate leprosy, you should be differentiating with one more condition, which is known as Pityriasis alba. What is Pityriasis means? Formation of scales. How will you differentiate? There will be, in the case of Pityriasis alba, it is Pityriasis, so scales will be present. So once you scratch, you will see there is a formation of scales, and you will ask, there will be absent of hypopigmentation, no hypoanesthesiatic patches. So this patch which will be there in children, which won't be having any sensory loss, it will be normal. There's the scaly white patches, it is known as Pityriasis alba, which is most commonly seen in the case of children. Okay? And next, if you are able to see this type of inverted saucer appearance, it will be seen in the case of BB type of leprosy. Whereas in India, the most common one, it is the BT type of leprosy. Okay, बहुत BD हो रहा आज तो, ठीक है? Just remember this thing. Next, if you are able to see multiple and almost symmetrical, not symmetrical, so it is what? It is the BL type of leprosy. And if you are able to see this type of multiple symmetrical and this type of leonine faces, all of this thing, all of these things, it will be suggestive of this LL, lepromatous type of leprosy, LL type of leprosy. Fine. And we know in the case of possibacillary leprosy, हम क्या करेंगे? We'll give this drug, like will dapsone and rifampicin, and like if it is uniform MDT, then we also add clofazimine. We'll give this drug for 6 months. Whereas in the case of multibacillary, we'll give for 12 months. Okay. And while giving this drug, what we'll do means this can cause lepra reaction. Type 1 lepra reaction and type 2 lepra reaction. हमें पता है. Type 1, it is what? It is this HSN4. Whereas type 2, it is hypersensitivity reaction. Type 3. Okay, type 3. Okay, in the case of type 1 reaction, okay, in the case of type 1 reaction, which is what? Which is hypersensitivity reaction 4, there will be formation of granuloma. There will be the granuloma formation, and it will be treated with steroids. Whereas in the case of erythema nodosum leprosum, which is the type 2 lepra reaction, it is a type 3 hypersensitivity reaction, and And see here, there will be a formation of papules, nodules and macules. There will be a rule of 5. Like see, 1 plus 4 is 5 and 3 plus 2 is 5. Okay, so type 2 Lepra reaction, it is type 3 hypersensitivity reactions, whereas type 1 Lepra reaction, it is type 4 hypersensitivity reactions. Fine. So here there will be formation of papules, nodules and macules. Papules, nodules and macules along with this Glovenstock formation and Glovenstock formation of anesthesia. So इतना आपको याद रखना. So you should remember at least this much about this case of leprosy. ठीक है, लेप्रोसी में तुम्हें इतना याद रखना है. और पार्सिबेसिलरी कैसे बोलेंगे? If there is 5 lesions with no involvement, no nerve involvement, it is known as parsibacillary. If it is more than 5 along with at least 1 nerve involvement, it is known as multibacillary. It is known as multibacillary leprosy. ठीक है, we'll move on to few neurocutaneous syndromes and then we'll finish up with derma. Fine. We see about this neurocutaneous syndrome. Okay, one is this NF, neurofibromatosis. It is an autosomal dominant. See, there are 2 NF. NF1 and NF2. If we count this neurofibromatosis, then it will be consisting of 17 alphabets. So NF1, it is because of this chromosome number 17 defect. So NF2, it is 2. So see, you see in skull, what you see? You will see this ice cream cone shaped, bilateral ice cream cone shaped acoustic schwannoma. It is 2 ice cream, right? It is not 1 ice cream, it is 2 ice cream. So it is 2-1 and it is NF2 and it is what it is? The chromosome number 22. It is the chromosome number 22. इतना आपको याद रखना है. It is the chromosome number 22. Fine. In the case of NF, you will be able to see this type of spots, which is known as what? Which is known as café-olate spots. It is known as café-olate macules or café-olate spots, and followed by these are this neurofibroma. Okay, neurofibroma, and an eye you will be able to see. This leash nodules, and axilla you will be able to see this type of freckling in the axilla. Okay, there will be a formation of freckles in the axilla, and here you will be able to see this type of leash nodules. Okay, इतना आपको याद रखना है जरूरी है. ठीक है, whereas in NF1 it can be associated with this pseudoarthrosis of tibia. Pseudoarthrosis of tibia. Yeah, good Dr. Anash, good Dr. Kanyon, and good Dr. Gautam. Good. Then this is what? This is our Bonovillis. This is also known as tuberous sclerosis. This tuberous sclerosis, it will be having this triad. Okay, this is known as epilo. Okay, what is this epilo? Means there will be epilepsy, there will be low IQ, and what will be there? There will be adenoma sebaceum. So it is what it is, this Vox triad. It is not Vox triad. Vox triad will see in a case of keratoconus. It is the Vox triad will see in a case of tuberous sclerosis. And in case of tuberous sclerosis, you will be able to see this type of hypomelanotic macule. There is a white-like macule, which is known as ash leaf macules. And here around this face or around this lumbar region, you will be able to see this type of patch, which is known as what? Shagreen patch. And there will be small potato tumors, it is known as what? Facial angiobromas, also known as what? Adenoma sebaceum, इतने याद रखो. ठीक है. Next, this tuberous sclerosis can be associated with this ungual fibroma, this fibrous and cephalic praves, and there will be a presence of this cortex. There will be presence of this tubers. Tubers can be present here, and also you will be able to see this one which is known as subependymal giantsal astrocytoma. This is also seen in a case of tuberous sclerosis. We will see this subependymal giant astrocytoma will be seen in a case of tuberous sclerosis. And in lungs, you will see this lymphangiomyomatosis. There will be large cystic swellings will be there. Lymphangiomyomatosis. And in kidney, you will see this angiomyolipoma. There will be vessel, there will be bleeding, there will be vessel, there will be lipids, and there will be muscles. There will be bleeding, there will be lipids, and there will be muscles. It is known as bilateral angiomyolipoma. And next one is the lymphangiomyomatosis. So all of this following will be typically seen in a case of tuberous sclerosis. It will be seen in a case of tuberous sclerosis. आपको याद रखना ही रखना है. Next, if you are able to see this type of Port-Wine stain along with the features of glaucoma, and here you will be able to see this type of tram tract calcification, and tram tract calcification sometimes associated with this intracranial calcifications. So Port-Wine stain, glaucoma, and tram tract calcifications, all of them will be seen in a case of Sturge-Weber syndrome. Okay. Next, about this first part, if you see this basal cell carcinoma, also known as rodent ulcer. This rodent ulcer, it is most commonly seen around this area where there is more exposure to the sun. Okay, where there is more exposure to the sun. See, it can occur near to the ear lobe, around this nasal area as well. There you will be able to see there will be a central ulcer, and followed by which there will be this dilatation of this vessel. They are known as telangiectasia. Telangiectasia. Okay, telangiectasia. Remember, there will be ulcer along with this telangiectasia, and we know, like other side, it can present with this squamous cell carcinoma. This is how this ill-defined squamous carcinoma present with, and we know in the case of squamous cell carcinoma, there you will see there is a presence of keratin pods. Okay, fine. And next, this is this melanoma, and we know melanoma, it will be having the few features. What are them? If you see this melanoma, it will be following this ABCD rule, and it will, and based on this depth, we'll see whether this is malignant or if it is going to metastasis. Fine. So next to this basal cell carcinoma, it is the most common and most common one. It is the most common skin tumor. It is the basal cell carcinoma. Whereas in the case of squamous cell carcinoma, it is next to this one, and it will be showing, or we will be able to see this keratin pulse in the case of squamous cell carcinoma. Malignant melanoma, it will be positive for this HMB 45 along with this S100. So these are the few things, these are the main things you should remember from this dermatology perspective. Fine. And this is what everyone tells, like just when everyone is sleeping, make sure you are reading. Okay, so that you can sleep after January 12. Okay, so that you can sleep after January 12, because if you don't sacrifice your sleep now, you will sacrifice your sleep for next 6 months. Okay, so make sure you, means there will be bit hard times, and make sure you are making your effort with very silently, with inside you, with very by your own self. Okay, because the victory is not for anyone else in the world, it is for you, your recognition, and it is your victory, and only you can do it. Okay, that is the motivation, that is the thing that you should have till your FMG examination. Once it's done, just keep everything out of mind, have a enjoyable days then after it. Fine. That's it about dermatology, guys.